What I'm about to share with you today is information that I genuinely wish every senior knew by heart, not because it is complicated, not because it requires any special equipment or any medical training, but because it is the kind of knowledge that sits quietly in the back of your mind until the moment you need it, and in that moment it can mean the difference between a full recovery and permanent disability, or between life and death. Every year in the United States alone, approximately 800,000 people have a stroke. That is one stroke every 40 seconds. And of those 800,000 people, a significant proportion are seniors who are alone when it happens at home, in the garden, in the bathroom, in the kitchen, in the ordinary spaces of ordinary life where no one is immediately there to help and where the ambulance is minutes away. Those minutes matter more than most people realize. Brain cells die at a rate of approximately 1.9 million per minute during an ischemic stroke. Every minute that passes without intervention is brain tissue lost, function impaired, recovery made harder. And yet, most people, most seniors specifically, have never been taught what to do in those critical minutes while waiting for help to arrive. Today, that changes. My name is Dr. James. Welcome back to the channel. And today, I am going to teach you the 3-minute protocol that every senior and every family member of a senior needs to know, understand, and be ready to use at a moment's notice. Before I walk you through the protocol itself, I want to make sure you understand the biology of what is happening during a stroke, because that understanding will help you appreciate exactly why each step of this protocol works and why the sequence matters. An ischemic stroke, which accounts for approximately 87% of all strokes, occurs when a blood clot blocks an artery supplying blood to the brain. When that artery is blocked, the brain tissue downstream of the blockage is immediately deprived of oxygen and glucose. Within seconds, the neurons in the core of the affected area begin to lose function. Within minutes, if blood flow is not restored, those neurons begin to die. But here is something critically important that most people do not know. Around the dying core of the stroke, the area of immediate, irreversible cell death, there is a surrounding region of brain tissue called the penumbra. The penumbra is a zone of brain cells that are functionally impaired but not yet dead. They are receiving some residual blood flow from collateral vessels, enough to keep them alive, but not enough to keep them fully functional. The cells of the penumbra are in a race against time. If blood flow is restored quickly enough, penumbral cells can survive and recover. If the blood flow deprivation continues, the penumbra progressively converts into dead tissue, expanding the area of permanent brain damage. Everything in stroke medicine, from the clot-busting drugs given in the emergency room to the interventional procedures performed by neuroradiologists, is aimed at saving the penumbra, and the actions taken in the minutes before medical help arrives can influence the size and survival of that penumbral zone in ways that meaningfully affect outcome. This is the biological basis of the protocol I am about to teach you. The very first thing, the zero step that happens before anything else, and that takes approximately 30 seconds, is recognition. You cannot respond to a stroke you do not recognize. And the speed of recognition in stroke is everything. The acronym that stroke neurologists have developed to help the public identify stroke symptoms is F.A.S.T, and I want to teach you a slightly expanded version called F.A.S.T that captures additional warning signs that the original F.A.S.T acronym misses. B stands for balance, a sudden loss of balance or coordination, stumbling, or an unusual difficulty walking that appears abruptly and without explanation. E stands for eyes, sudden vision, changes, double vision, loss of vision in one eye or in part of the visual field, or the sensation that something has changed dramatically about how you see. F stands for face, ask the person to smile. Does one side of the face droop? Does the smile appear asymmetrical or crooked in a way it was not moments before? A stands for arms, ask the person to raise both arms to shoulder height and hold them there. Does one arm drift downward involuntarily? Can they raise both arms equally? S stands for speech, ask the person to repeat a simple phrase. Is the speech slurred, strange, confused, or absent? Do the words come out scrambled or incomprehensible? T stands for time. If any of these signs are present, time to call emergency services is now, not after a glass of water, not after lying down to see if it passes. Now. The time it takes to recognize and call for help is the first and most critical element of the entire response. Do not let uncertainty delay you. When in doubt, call. A false alarm costs nothing. A delayed call costs everything. Now, with emergency services called and on their way, you are in that critical window, the minutes between recognition and the arrival of help, during which the actions you take can meaningfully influence the outcome. The first and most important action in this window is positioning. Help the person, or if you are experiencing stroke symptoms yourself, position yourself in a specific way that optimizes blood flow to the brain and reduces the risk of aspiration if vomiting occurs. The correct position is lying on one side with the head slightly elevated, approximately 15 to 30 degrees above the level of the heart. Not flat on the back, which allows the tongue to fall backward and potentially obstruct the airway, and does not provide the slight positional elevation that supports cerebral perfusion. Not sitting fully upright, which reduces cerebral blood flow pressure in a brain that is already receiving inadequate blood supply. On the side, head slightly elevated. This position keeps the airway open and protected, reduces the risk of aspiration if nausea or vomiting occurs, which is a common stroke symptom, and maintains a posture that supports the best possible blood flow to the compromised brain tissue. If the person is conscious and able to communicate, reassure them calmly and consistently. Panic and agitation increase heart rate and blood pressure in ways that can worsen the stroke outcome. Your calm voice and steady presence have a genuine physiological effect on their stress response. Keep talking to them. Keep telling them that help is coming. Keep them as calm as you can while keeping yourself calm too. The second element of the 3-minute protocol involves what not to do, and I want to be very specific about this because well-intentioned but incorrect actions in the first minutes of a stroke can cause serious harm. Do not give the person anything to eat or drink. Swallowing is frequently impaired during stroke. The neural control of the swallowing reflex can be disrupted by the same brain injury causing the other symptom, and giving food or water to someone whose swallowing is impaired can cause aspiration, where fluid enters the airway and lungs, adding a life-threatening complication to an already critical situation. Do not give aspirin unless you have been specifically instructed by a physician that the person should take aspirin in this situation. This recommendation surprises many people because aspirin is commonly associated with heart attack response, and because aspirin does work beneficially in ischemic stroke by preventing further clot formation. However, approximately 13% of strokes are hemorrhagic, caused by a bleeding vessel rather than a clot, and aspirin given during a hemorrhagic stroke worsens the bleeding and can be fatal. Without imaging to confirm the stroke type, giving aspirin introduces a meaningful risk that must be weighed against the benefit. Unless a physician has specifically told you or your loved one to take aspirin at the first sign of stroke, the default recommendation is to leave this decision to the emergency medical team, who can assess the situation with proper equipment. Do not leave the person alone. Do not allow them to walk around unsupported. The balance and coordination disruption of stroke makes falls a serious risk. And do not delay calling emergency services because the symptoms seem to be improving. A transient ischemic attack, sometimes called a mini-stroke, produces symptoms that resolve within minutes to hours, but it is one of the strongest predictors of a major stroke within the following 48 to 72 hours. Improving symptoms are not a reason to avoid emergency evaluation. They are a reason to get evaluated urgently. The third element of the protocol is information gathering, and it takes approximately 60 seconds but can save critical time in the emergency department and significantly influence treatment decisions. When emergency services arrive and when you communicate with the 911 operator, the most important piece of information you can provide is the time the symptoms started or the time the person was last known to be normal. This information is not secondary. It is one of the most critical clinical data points in stroke medicine. The clot-dissolving drug TPA tissue plasminogen activator, which is the primary medical treatment for ischemic stroke, has a treatment window. It can only be safely administered within 4.5 hours of symptom onset. The mechanical thrombectomy procedure, where a catheter is used to physically remove the clot from the blocked artery, has a window of up to 24 hours in selected patients. Every minute of uncertainty about symptom onset is a minute of treatment window potentially lost. If you can tell the emergency team precisely that symptoms began at a specific time, you are giving them the information they need to make rapid, informed treatment decisions that can determine whether the patient receives the most effective treatment or falls outside the window for it. Note the time on your phone the moment you recognize the symptoms. Take note of what the person was doing immediately before the symptoms appeared. If the person woke up with symptoms, which is common because strokes frequently occur during sleep, note the time they were last seen to be normal, which is typically when they went to bed. This information is as valuable as any test the emergency team can run. I also want to teach you something that is increasingly being discussed in emergency medicine circles, and that applies specifically in situations where a stroke is occurring and the person is alone, because for many seniors, this is the most likely scenario. If you are alone and you believe you are experiencing stroke symptoms, the most important action is the same first action: call emergency services immediately, even before you have confirmed all the symptoms, even if you are not certain. Tell the operator your address first, before anything else, in case the call is dropped or you lose the ability to speak. Then describe what you are experiencing. Then unlock your front door. If you can do so safely, this allows emergency responders to enter without delay if you become unable to respond. Then get onto the floor in a safe position, not on a bed or sofa, from which you could fall in the recovery position on your side with your head slightly elevated on your arm. Stay on the line with the emergency operator if at all possible. Do not try to drive yourself to the hospital. A stroke impairs judgment, coordination, and reaction time in ways that make driving acutely dangerous for you and for everyone around you. Stay where you are, in the safest position you can achieve, and wait for help. Beyond the acute response protocol, I want to take a few minutes to talk about the things you can do today, right now, before any stroke occurs, that significantly reduce the likelihood of ever needing to use this protocol, because the best stroke response is the one you never have to perform. The modifiable risk factors for stroke are well established, and their management is genuinely effective. High blood pressure is the single largest modifiable risk factor for stroke. It is responsible for approximately 50% of all strokes, and even modest reductions in blood pressure translate to significant reductions in stroke risk. Knowing your blood pressure numbers, working with your doctor to keep them within healthy ranges, and taking any prescribed blood pressure medications consistently are the most powerful stroke prevention actions available. Atrial fibrillation, the irregular heart rhythm that allows blood to pool and clot in the heart's chambers, sending clots to the brain, is responsible for approximately 15 to 20% of all ischemic strokes and is dramatically undertreated in the senior population. If you have ever been told you have AFib, if you experience palpitations, irregular heartbeat, or unexplained breathlessness, please ensure that your cardiac rhythm is being appropriately monitored and managed. The dietary interventions we have discussed across multiple videos on this channel: reducing refined carbohydrates, managing insulin levels, consuming anti-inflammatory foods like pomegranate and fatty fish and colorful vegetables, all contribute to the vascular health and endothelial function that reduce stroke risk over time. And aspirin therapy for stroke prevention, which is appropriate for some seniors with specific risk profiles but not for all, is a decision to make with your physician based on your individual circumstances, not a blanket recommendation. What I want you to carry away from today's video is both urgency and empowerment. Urgency because stroke is a genuine emergency where minutes determine outcomes in a way that is direct, measurable, and unforgiving. Empowerment because you now know what to recognize, what to do, what not to do, and what information to gather in the minutes that matter most. Print this protocol, share it with your family, review it with the seniors in your life. Because the 3 minutes before help arrives are not empty waiting time, they are active, purposeful, potentially life-saving minutes during which knowledge is the most powerful tool you possess. My name is Dr. James, and if this video gave you information that could save a life, please hit that thumbs up button right now and share this video immediately with your family, your friends, anyone over 60 in your life, anyone who lives alone, anyone whose well-being matters to you. This is the kind of information that earns its place in every senior's knowledge base and every family's emergency preparedness conversation. Leave me a comment below and tell me whether you knew all of this before today or whether something here was new to you. I read every comment and genuinely value hearing from this community. And if you are not yet subscribed to this channel, please subscribe right now and ring that notification bell, because every week I bring you the honest, evidence-based senior health content designed to keep you informed, prepared, and empowered for whatever life brings. Subscribe right now. Be prepared. I will see you in the next video.